Welcome, everyone. If you're prepping for your MRCOG exams right now, or maybe you're just looking to absolutely nail down your clinical protocols for obstetrics emergencies, you are in the exact right place. Today, we're bringing you a deep dive explainer on the RCOG Green-top Guideline No. 56, which covers maternal collapse in pregnancy and the puerperium. This is super high yield, critical information. We're going to break it all down so you can completely master the protocols that, quite literally, save lives. So let's just jump right in. To really wrap our heads around why maternal resuscitation is so incredibly unique, we need to start with a number that should instantly grab your attention: 30 to 40%. You see, from around 20 weeks of gestation onwards, that gravid uterus heavily reduces venous return whenever a woman is lying in the supine position. The direct consequence of that, maternal cardiac output plummets by up to 30 to 40%. This physiological reality fundamentally changes the entire game when it comes to cardiopulmonary resuscitation in a pregnant patient. Here is our quick roadmap for today's explainer. We'll define maternal collapse, look at the physiological changes, and dive into the 4 H's and E diagnostic framework. After that, we'll cover the modified ABCDE steps, the highly time-critical Perimortem caesarean section protocol, and finally wrap things up with teamwork and debriefing. Section 1. Defining maternal collapse and establishing our clinical parameters. It's super important that we're all operating with the exact same clinical baseline here. The guideline defines maternal collapse as an acute event involving the cardiorespiratory systems and, this is key, the central nervous systems, requiring immediate intervention. So we aren't just talking about full cardiac arrest. A sudden alteration of consciousness can also be a massive red flag of critical illness. Outcomes for both the mother and the fetus depend entirely on prompt, laser-focused resuscitation. Every single second counts. Now, for you MRCOG candidates, understanding the grading of these guidelines is basically non-negotiable. It frames our entire approach. You've got recommendations ranging from grade A, which are backed by high-quality meta-analyses, all the way down to good practice points, which rely on the clinical experience of the guideline development group. Knowing the difference between a hard evidence-based mandate and a good practice point is going to serve you incredibly well, not just in your exams, but out there on the labor ward. Section 2, Physiological Changes in Pregnancy and Understanding Maternal Vulnerability. We really need to look at why maternal resuscitation throws so many unique curveballs compared to standard adult resuscitation. The RCOG outlines some critical grade C recommendations about these physiological hurdles. Pregnant women have naturally increased oxygen consumption paired with changes in lung function and diaphragmatic splinting. Clinically, this means they become hypoxic so much faster. Plus, gastrointestinal changes drastically increase the risk of aspiration. And if that wasn't stressful enough, difficult intubation is way more likely in pregnancy. Anyone responding to these emergencies absolutely has to anticipate these hurdles. And this right here perfectly highlights our main mechanical problem. This grade C guideline states outright that aortic caval compression significantly reduces not just baseline cardiac output from 20 weeks onwards, but the actual efficacy of your chest compressions during resuscitation. Doing standard chest compressions on a supine pregnant woman at 30 weeks is simply not going to generate the systemic perfusion you need purely because the vena cava is being crushed by the uterus. Section 3, Identifying Causes using the 4 H's and E diagnostic approach. Finding the underlying cause of the collapse is everything, because if you can reverse the cause, survival rates shoot right up. You're probably familiar with the classic 4 H's of cardiac arrest: hypovolemia, hypoxia, hypo or hyperkalemia, and hypothermia. But in obstetrics, we add a crucial E to that list: E for eclampsia and intracranial hemorrhage. This modified mnemonic has to be your mental anchor in an emergency. For example, when you're checking for hypovolemia, remember that obstetric bleeding can be entirely concealed. When checking hypoxia, you've got to think about peripartum cardiomyopathy or a pulmonary embolism. You need to systematically rule these out while you are actively resuscitating. Section 4, Modified ABCDE Resuscitation. Let's put this theory into practice. This is where we adapt the standard Resuscitation Council UK algorithms specifically for maternal physiology. The contrast here is huge. A standard patient is kept flat and supine for CPR. A maternal patient over 20 weeks requires manual left lateral displacement of the uterus. A standard airway might be an easy open. The maternal airway is a high-risk zone for difficult intubation and aspiration. The basic ABCDE steps, airway, breathing, circulation, disability, exposure, stay the same, but exactly how you execute them changes entirely. Let's break down those modified initial steps. Step 1, manual displacement of the uterus to the left, is an absolute, non-negotiable necessity to allow for effective chest compressions. Step 2, because of that rapid onset of hypoxia we talked about, you've got to flood the system with 10 to 15 liters per minute of supplemental oxygen. Step 3, immediate vascular access. You need 2 wide-bore cannula in there, minimum 16 gauge. You want to be aggressive with volume replacement, but, and here is a very vital good practice point to file away, you must exercise serious caution with fluids if you're dealing with preeclampsia or eclampsia, to avoid pushing the patient into fluid overload and pulmonary edema.
Section 5. The Perimortem Caesarean Section Protocol. These are the most time-critical interventions.
4 minutes, that is your first major trigger threshold. For women over 20 weeks of gestation, if there is absolutely no response to correctly performed CPR within 4 minutes of the maternal collapse, a PMCS must be undertaken. And listen, the primary goal of this procedure isn't just fetal salvage, it is fundamentally to assist maternal resuscitation by getting rid of that aortocaval compression completely. Which brings us to the ultimate target threshold, 5 minutes. The guideline is incredibly explicit here. Delivery should ideally be achieved within 5 minutes of the collapse. The golden 5 minutes. Burn that phrase into your brain. Hitting this target requires flawless team coordination and a rapid, incredibly decisive approach from the senior obstetrician on the floor. So how do we actually hit that crazy 5-minute target? The RCOG gives us very specific good practice points. First off, do not move the patient. PMCS has to be performed exactly where the maternal collapse occurred. Trying to rush them to an operating theater is only going to waste precious time. Second, use whatever incision gets you the absolute fastest access. Usually that's a midline vertical or a suprapubic transverse incision. Third, a scalpel and umbilical cord clamps should permanently live on the resuscitation trolley in any clinical area where a collapse might happen. And lastly, because maternal cardiac output is effectively 0 at this point, no anesthetic is required to start the procedure.
Section 6. Teamwork and post-event debriefing. The logistics and clinical governance here are heavily assessed, and for good reason. You literally cannot do this alone. According to good practice points, the emergency call has to bring a massive multidisciplinary effort. We're talking the general arrest team, a senior midwife, the most senior consultant obstetrician available, and the consultant obstetrician anaesthetist. Also, if the collapse is antepartum and they are past 22 weeks and 0 days of gestation, get the neonatal resuscitation team in there early, because a delivery is highly, highly likely.
And look, even when a resuscitation goes perfectly and is completely successful, the psychological impact of an event like this is profound. The guideline makes it a point to note that maternal collapse is strongly associated with post-traumatic stress disorder, postnatal depression, and tachophobia, which is a severe fear of childbirth. Because of this, offering a holistic debriefing with a competent professional is strongly recommended. And that's not just for the woman and her family, it's for the staff involved, too. Mental health support is a mandatory continuation of this care. We've walked through the intense physiological challenges, the modified ABCDE protocols, and why rapid, decisive intervention isn't just recommended, it's required. So I'm going to leave you with this thought. Are you fully prepared to execute those modified steps and hit that critical 5-minute PMCS target in a real-world obstetric emergency? Take these guidelines, completely internalize them, and bring them into both your exams and your daily clinical practice. Thank you so much for joining me for this explainer, and keep studying hard.